Special
Awesome.
powers.
There you go.
Yes, I don't have the powers. And you can all see that all right, and you can't see my cheat sheets.
No.
Yeah, looks
That's
good.
Awesome.
perfect. Perfect.
Excellent.
All good. All right, we might get started. Thank you everyone for joining us for today's vertical integration session, which is on urine trouble, presented by Dr. Anthony Elias. My name's Rochelle. I'm an education officer for the Primary Health Network. Before we begin, I'd like to acknowledge the traditional custodians of the lands in which we all live and work on, and pay my respects to elders past, present, and emerging, and extend that respect to any First Nations people joining today. Just a couple of things before we start. Throughout the presentation, if you have any questions, please pop them in the chat box, and just seeing how we go for time, we can go through them at the end. As usual, your feedback is important. It supports us to provide future educational sessions. So I'll pop a link and a QR code to the Slido evaluation in the chat towards the end of the session. And just lastly, the session today is being recorded. So with that being said, please just be mindful when asking any questions or referring to any case studies, you ensure to not give any identifying details about your patients or colleagues, please. So I'll hand over to Dr. Tony, who will start his presentation.
Excellent. Hi, also. I'm Tony Elias. I'm one of the infectious disease doctors and microbiologists at Gosford Hospital. And I thought today we'll talk primarily about urinary tract infections and look at a little bit of epidemiology, go through an update on ETG because it's recently changed. And maybe talk a little bit on recurrent and relapsed UTIs because it's a big thing in your world. And if we get time at the end, we will talk a little bit about multi-resistant organisms and the rise of those, because it's, of course, you can't talk about one of the big drivers of multi-resistant organisms is things like recurrent UTIs, where we do end up using a lot of antimicrobials. So starting off just with a bit of the basic microbiology on urinary tract infections. This is actually, we've learnt a bit more in the last few years about this, and our traditional thinking of some organisms has changed. Now, by far and away, as you all know, the most common cause of a UTI is intestinal flora migrating up the urinary tract, and E. coli is the big player here. It's got the ability to form little pili that can adhere to the urinary tract wall and migrate up the wall and persist in the urine. Occasionally you can get UTIs from bacteremic spread. The classic example is Staph aureus. So 10% of the time you grow staph in the urine, it's actually due to bacteremia. It can also be due to devices and things, but typically, it spreads through the blood and latches to the kidneys, finds its way into your bladder that way. But E. coli is really the key player. Now, once you get to people with anatomical and functional abnormalities, you start to see some other organisms. Still, E. coli is the big player, but other things like Proteus, Klebsiella, Serratia, Pseudomonas start coming in. With the iatrogenic, like people who've had urological procedures and stents, we start seeing some unusual organisms. Anything becomes fair game. Bugs that can't get up the urinary tract suddenly get an opportunity to get introduced. So once again, some environmental gram-negatives. So SUDS are there. Enterococcus becomes a player here. We don't see Enterococcus outside of this setting usually, although you keep growing it in urine, but its significance is a bit dubious. And some of the staph species. Candida is probably one of those ones you really primarily see in iatrogenic infections. We often grow it in urine. It's usually just a colonizer of your perineum or device. And when it is relevant, it often causes like ureteric obstruction. Now, this is just looking at data from our lab, and now we're a hospital lab, so it's a bit different to the community. But you get an idea of what the key organisms are. So E. coli, more than 50% here, probably about 60% on this. In those studies, they say 70 to 95%. It probably is close to that because when you look at Enterococcus, yeast, and Pseudomonas, coming, third, fourth, and fifth, probably only about 10 to 20%, even in a hospital setting, of these are going to be significant. And some of these others down here, Group B strep, a lot of the coagulase negative staph, they're all quite dubious when you grow them. And in the hospital, we have a lot more patients, I guess, with catheters and urine that festers on the ward for ages before getting to the lab. So what's an insignificant amount of organism becomes significant. Now, how do we know what organisms, when you grow them in a urine MCS, actually are causing cystitis? Well, this is an interesting study. It's a bit of an old one, but I like it. And I don't think it's ever been replicated because it's a bit difficult to do. But basically, they looked at women from the age of 18 to 49. They had about 236 episodes of cystitis in 226 women and managed to get 202 paired specimens of midstream urines, and then also did in-out catheters into the bladder. And the thought is, midstream, you can contaminate that. In-out catheter, you're going, putting in a fresh catheter, collecting your urine. It's a more sort of sterile and informative specimen. And this is what they saw. So generally when you grew E. coli in your midstream, it was also in your bladder. But when you look at, and same with Klebsiella pneumonia, it's another enteric, which also can have pili. But when you look at Enterococcus and Group B strep, often grew in the midstream, very rarely grew in the bladder. So what that tells you is these organisms are probably not causing UTIs when you grow them, and there might be another organism or another etiology for if there is pyuria. And the way you think of it is these organisms, the E. coli's and the Klebs, they're geared towards making, getting up into urinary tract and adhering. Whereas these ones, they're like sacks of potatoes. They can't really migrate, only if you sort of introduce them or have some sort of way of allowing them to, you've got to help these to get into your urinary tract for them to cause problems. And we often grow them in urine. Now, I thought we'll talk a little bit about indications before we talk about the lab side of urine culture, because it's good to have an understanding of that. Now, in most instances when I am treating a patient for a UTI, I collect urine, but there has been a bit of a shift to say treat empirically based on symptoms and only obtain a urine in certain circumstances. But those circumstances end up being most UTIs anyway, or most patients who you're going to be treating anyway. So in a symptomatic patient with a urine, collect a urine in people who fail to respond within a week, if the diagnosis is uncertain, if they're pregnant, if they're male, if they've got a history of recurrent UTIs, or if they're at risk of resistant organisms. And these include aged care patients, people who've had recent antibiotics, people who've had hospitalization. You end up probably capturing most people with symptomatic UTIs in those at the end of the day. And in those who are asymptomatic, the only instances where we would like, I guess a urine microscopy are those who are having elective urological procedures or in the setting of routine in pregnancy. Now, all of this about transport and processing. I guess the two key things to remember is method of collection's importance, because how we report our urine and interpret our urine is based on how it was collected. And we have different algorithms on how we treat urine from different sites or different collection types. And also, as a lab, we need to process these ideally within 2 hours, and that can't happen usually, but what we end up, if you can't do that, you have to refrigerate it and then we can set it up. And the reason for that is so much of your interpretation of a urine is how much bacteria you grow. And if you're going to leave a urine pot sitting around for a few hours, what's suddenly insignificant growth is going to become significant growth. Now, we all know about urinalysis, so I won't really talk about this, and it's a potentially useful tool to do. Now, in terms of microscopy, we know what you probably all know what these mean. If you've got squamous cells, it indicates contamination. Leukocytes suggest inflammation, and this is probably a key thing for your diagnosis of UTIs. We used to look at bacteria under microscopy, but now most labs don't do it anymore. If you saw bacteria on microscopy, it basically meant you'll grow more than 10 to 8 organisms. So you'll know they had a UTI marginally quicker. But now, it's not, when you collect a urine, it's not a critical specimen. You don't really need to know instantly if there's a lot of bacteria in it. You can afford to wait 24 hours and see what you've grown. So most laboratories now just do the microscopy for squamous cells, leukocytes, erythrocytes, and then set up culture rather than quantifying bacteria. Now, culture's worth talking about because what we do in the lab is probably a dark art. But what we're looking for, or what we're trying to grow in the lab, is we're looking to see if we get more than 10 to the 6 organisms. If we get more than 10 to the 6, we generally report it as growth. If there's less than 10 to the 6, there's no significant, or there's no growth. Now, we work up organisms. Different labs have different algorithms, but generally in our lab, if we have pure growth of an organism more than 10 to the 6, we will work it up and we will report it. And then it varies based on your interpretation, based on the parameters such as pyuria and squamous cells, if you actually will work up some of these things. Now, how do we get 10 to the 6 bacteria? How do we grow it? Well, we use this little tiny yellow 1 microliter loop. We dip that in urine, we streak the plate, and if you grow 1 colony of bacteria on that plate, that's 10 to the 6. If you grow 10, it's 10 to the 7. If you grow 100 or more, it's more than 10 to the 8. So it's that crude, and we look at the plate after 24 hours. This is an example of a plate we use. On this side, you've got a chromogenic agar, and different organisms produce different colors. Or E. coli produces this nice pink color. There are a few other organisms that can do that, so you still need to identify it. And this side over here has a antibiotic that kills gram negatives, colistin, and this allows you to see if there's sneaky little gram positives that are a bit more indolent and going to be outgrown. So if you've got stuff here and here, then it's you're more likely to find if there's mixed growth, and that will help you interpret the urine. Now, we've more invasively collected specimens, so an in-out catheter or a urological catheter. So, or urological procedure, so something collected during cystoscopy. We go down to 10 to the 5, and to do that we use a 10 microliter loop. So this loop is dipped in urine and then we streak the plate. So 1 colony is 10 to the 5, 10 to the 6, and so on. So we look a bit harder for unusual organisms and things that are a bit more indolent with this. We also set up a few different plates, which I'll talk about later. Now, urine is not a sterile sample. This is the difference between getting some urine and throwing it on a blood agar plate and incubating for 24 hours and then incubating for 72 hours. So there is always going to be stuff in urine. if we are standardized in the way we do things, we would hopefully not be overwhelmed by plenty of organisms. But it's just a reminder that, if you allow things like urine and to sit in a jar and fester for a while, you will grow things. And if we incubate for too long, we will grow more things. So this is an example of an algorithm used. I think this is our old one we used to use in our lab. We've recently changed because we're moving over to more of a statewide standardized process now in use public pathology. So all labs are going to be trying to do the same thing. So as I said, if you got less than 10 to the 6, we say no growth. If we've got, say, 10 to the 6, but less than 10 to the 7, it's no significant if it's mixed. But if it's pure and there's a lot of white cells and there's no squamous cells, we'll work it up. And so on. You can see there's different ways how we handle it. Catheters we treat a little bit different. Suprapubic aspirates, no one does them anymore now, but I guess cystoscopy urines or in-out catheters would probably go down to 10 to the 5. Now, just giving you an idea of, this is again, hospital setting, so there is a bit more resistance here compared to the community, but surprisingly not that different, actually, when I look at the DHM antibiogram. This is just to look at our resistance patterns over the last 5 years. Because it's useful to know that, it's good to know this because this is going to inform our antibiograms and this is going to inform our empiric treatment options and what we're going to be recommending. So you can see E. coli, this is the one we're mainly interested in. Resistance to ampicillin is now pretty high. It's about 43%, so 57 are sensitive. Augmentin's okay, it's in the 80s. Trimethoprim's hanging on to 80 as well as Bactrim. Now there has been a bit of a change in the way we report this recently, so it's probably overstated. The sensitivity, it's 80% sensitive here, but it's actually more like 90 something percent, because I think the way we used to do sensitivities with Bactrim and trimethoprim was a little bit flawed. We used to do things on disc, and if we saw things growing in the disc zone, we used to say it was resistant, but that's been shown to be wrong. Nitrofurantone's very reliable. Aminoglycosides are pretty good. Worth looking at ceftriaxone. So ESBLs are resistance to third generation cephalosporins. So this gives you an idea about our ESBL rate, and it's about 9%. So that's up. For E. coli 20 years ago, it would have been about 1 to 2%. So that's creeping up. Not much marrow resistance in E. coli, but it is in some of the other species we're seeing that creeping up as well. So carbapenem resistant organisms. Fosfomycin, which we'll talk about a little bit later, is pretty good as well. So this sort of would inform things like the therapeutic guidelines in terms of what we recommend as empiric options. Doesn't have Keflex here. It would have been good to show you that. I think it would probably be something similar to Augmentin. Now, when treating a UTI, it's crucial to, I guess, differentiate between uncomplicated and complicated UTI. The problem is no one can actually give you a good definition as to what's a complicated and uncomplicated UTI, and it's always debated. And the reason why it's important is duration can be different, but also the agents can be different. So if we go looking at these again, for complicated UTIs, trimethoprim's not an option, nitrofurantone's not an option, fosfomycin's not an option. And that's because these are all antibiotics that concentrate in the bladder but don't actually get into tissues such as kidney or bloodstream in great levels, or prostate. They're not great agents in that setting. And also you use different doses for complicated UTIs. So now you'll see with TG, we push for augmentin TDS, not BD, for complicated UTIs. Keflex, rather than 500 BD, you're going to go a higher dose. So these this is, I guess, a new classification that came out last year from the Infectious Disease Society of America. And basically they've said uncomplicated UTIs are infections in both men and women. Men used to always be regarded as complicated, confined to the bladder. Complicated is infection beyond the bladder. So this is regardless of, risk factors such as transplant or abnormal urinary tract. It's saying, well, look, if people with complicated urinary tracts can have simple UTIs as well as complicated UTIs. They don't always have to be complicated. So this is part of, the combination of our antibiogram is really what has informed some changes in the therapeutic guidelines, as well as some of the new evidence about what organisms cause UTIs. You might remember when you did work in hospital, empiric treatment for urosepsis used to be ampicillin and gentamicin, because we used to worry about things like enterococcus that are always resistant to ceftriaxone, but because of increasing ampicillin resistance in E. coli and the fact we think things like enterococcus are not big causes of UTIs, it's now ceftriaxone and tobramycin, but that's in a more sepsis setting. But when it comes to acute cystitis, there have been some changes. So you'll see the recommendations here of nitrofurantoin, fosfomycin and trimethoprim as your first line agents, and Keflex as a second line agent. We'll talk a bit about fosfomycin. I personally feel a little bit uneasy about seeing this as a first line agent. It's convenient because you can give it as a once-off dose, but it's sort of, most labs they don't always test for it because you need to do a disc to be able to do it, a special disc. And also it's a great agent for the resistant organisms. It's nice to sort of keep it up your sleeve for, say, ESBL or carbapenem resistant organisms. It's often preserved, and it's something nice to have up your sleeve for your patients with who are known to be colonized with those resistant organisms. In pregnant women, it's similar. However, trimethoprim's omitted, and in males, there's poor evidence for fosfomycin. There is a case reports of it being used in males and being used for even complicated things like pyelo, having to repeat doses, but it's not great level evidence. What you'll notice with males is it is a little bit longer, even though the IDSA is now saying males don't necessarily meet criteria for complicated UTIs, but the recommendation is still to go longer. So pyelonephritis, there has been a bit of a shift to a shorter duration. So we used to go 10 to 14 days. It's come down to 7 to 10 days. There is actually one study recently which said, you could use ciprofloxacin for 5 days and that's adequate. Now for non-severe pyelo, who you're going to use something oral, you can see the higher dose of augmentin is there, the TDS dosing for 10 days. You can see Bactrim is there for 7 days, Keflex 1 gram QID, so high dose for 10 days, amoxicillin 1 gram TDS for 10 days. So it's high dose. That's the key thing. And the last line is ciprofloxacin if you can't use penicillins. For severe pyelonephritis, if there's you can empirically give one agent with gentamicin or tobramycin, but if they're in septic shock, they recommend going combination aminoglycoside and ceftriaxone. And the ceftriaxone dose for sepsis is 2 grams, whereas just severe pyelonephritis, it's 1 gram. All right, now fosfomycin, because many of you probably haven't come across this drug before. So the way it works, it basically inhibits the cell wall by inhibiting the MUR-A enzyme over here. It's just been approved in Australia for uncomplicated UTIs as a 3 gram once off, but has been used. There are cases where it's been reported to be used for like pyelonephritis and prostatitis, where you repeat it every 48 and 72 hours and has resulted in cure. It is convenient because it's a once-off dose and useful for those unreliable patients who you don't know if they're going to take a full course. But I really feel like this is where I disagree a little bit with TG. Like I do like it as a last line or an agent to be used for the multi-resistant organisms. We in our lab always set it up whenever we have an ESBL or a patient where there aren't many oral options. We'll set it up to give an extra oral option, but it's sort of not done as a routine thing. Now, many of you may not have access to the therapeutic guidelines, but the Central Coast Health Pathways is a great resource where you can access everything from the therapeutic guidelines, or a lot of the things from the therapeutic guidelines, as well as a whole heap of other useful information. So you'll have a copy of this presentation, so you can use these links. But as you can see, there are a few links here where you can look at UTI in children, pregnancy, recurrent UTIs, and it'll basically summarize TG. So for those who don't have subscriptions, you've got access, and it's regularly getting updated. Like these have been updated to the more recent update of therapeutic guidelines last year. Now you'll need to register for a personal account, and this is a link you can use, or the QR code. So you'll have access to this, and if you need support when accessing it, these are the number you can call, or you could email this email address over here. And I've been part of updating some of these topics on the pathways. You should note we also change it a little bit to suit our LHD, for example, including numbers of public health and for particular public health notifiable diseases. So we do make it more relevant to the coast. So now I was going to run through a few little cases and talk a little bit about urinary scenarios, various urinary tract infection scenarios. So this is a common scenario you guys have that we don't get as much in hospital. You saw staph, so midstream urine from a 22-year-old female with dysuria. She was commenced on Keflex. This is her urine microscopy. They looked for bacteria, which we don't do. This is what they grew, Staph saprophyticus. Now, you saw on our little, if we chart of what organisms we grew in hospital, Staph saprophyticus was very rare. It was like 1 to 2%, but that's because we're hospital and we don't get young women with UTIs very often in here. So it's about 5 to 15% of UTIs in the young women age group, and it's often because they're sexually active, and trauma can allow this organism to get into your urinary tract. interesting, you can see on this agar that I mentioned, it also has a little pink color, a bit not as juicy pink as the E. coli, but you can see it's growing on the gram-negative side, on the gram, the side that has the antibiotic that kills gram-negatives. So because this is a gram-positive, it's able to grow over here. So case number 2, we got a midstream urine from a pregnant woman at a 12-week antenatal visit. She's asymptomatic, no white cells. This is what we grew, so more than 10 to the 8 of E. coli. So would you treat her? You can type in the chat. I think I can. I'm keeping an eye on the chat. Well, we do. Yeah. So unknown user said yes, and yeah, absolutely. We do recommend treating in pregnancy because of the risk of developing pyelonephritis. So this patient has asymptomatic bacteria, so significant amount of bacteria without symptoms. It's generally not significant and usually just going to be contamination or colonization, but we do worry in some circumstances. So pregnancy, as we mentioned, if someone's going to have a urological procedure, because you want to avoid the risk of introducing organisms into your urinary tract, and children with vesicular ureteric reflux. I guess where it gets tricky, and it's not always straightforward, is sometimes it might be a resistant organism and there may not be an antibiotic safe in pregnancy. So when that happens, I generally recommend repeating. So if you've got a pregnant woman and there's no good agent you can give, you got to weigh up risk versus benefit, and I think repeating a urine's probably your get out of jail card in that instance, and not repeating post-treatment, repeating before treatment is what I mean. Now, this is a 84-year-old female from a nursing home with confusion, a little bit of white cells, lots of epithelial cells, so it's contaminated. This is a different urine plate that we don't use in our lab, but it's once again chromogenic. And as you can see, there's a mix. There's actually 3 different organisms here. So if you can see here, there's an E. coli, there's a strep, this one's called Aerococcus, this blue thing, and there's this white thing over here. So this is mixed growth. It's not really interpretable. You'd have to repeat. Now I saw in the chat, in a pregnant woman, if there's no leuks or red blood cells and it's mixed growth, if they're asymptomatic, yeah, I would repeat, see if you can get a better quality sample, because you want to be able to give the right antibiotic. The risk of pyelo, you want to be targeted with your approach. So a 19-year-old male with dysuria. I've now, oddly enough, put epithelials as the second, but he's got epithelial cells. No, he's got polymorphs as the second. He's got polys, lots of polys, no epithelial cells, and he's got no growth. So what are your thoughts on this? What other tests would you do? So Gordon said, is he sexually active? Yeah, so good. Like STIs would be the big thing in this age group. So this is called sterile pyuria. So the persistent finding of more than 10 white cells without significant growth. In that age group, yeah, at the top of your list is STIs. So what are the causes of sterile pyuria? I guess the obvious one is post-antibiotics, which we often see in hospital. They come in, get a dose of antibiotic. They manage to get blood cultures before the antibiotics, but urine can sometimes be a little bit slower to get to us, so we don't grow anything in the urine because they've had tobramycin or gentamicin. STIs, yep, particularly in our age group. So in someone from a TB endemic area, you're worried about tuberculosis, and we're seeing more and more tuberculosis on the coast as the demographic changes. But typically, this is more of a prolonged presentation. It's not going to be like our patient. Fungi can sometimes be a bit slower. Most candidas will still grow. Some are a little bit slower. The occasional viral things can cause a bit of pyuria, like HSV and HIV, but they're quite uncommon if they've been to Africa. Schistosomiasis, and this is a big another consideration and something we look out for in the lab occasionally if we know someone has a history of sterile pyuria. Other bacteria, so Aerococcus, Corynebacterium, some anaerobes, Leptospira, they're less common causes. Aerococcus not that uncommon, but they sometimes take up to 48 hours to grow, some of these, or some of them don't grow, like Leptospira. So we like to know if the patient's had a history of persistent sterile pyuria and so they're not at risk of STIs. And there's, of course, a whole heap of non-infectious things that can cause sterile pyuria. Now, our lab approach when we see sterile pyuria, we usually just have a comment. The presence of white cells without significant growth might be from recent antibiotics, an infection with special growth conditions such as those indolent organisms or tuberculosis, renal tubular inflammation, that's quite common, instrumentalization in hospital, or urethritis. So what we do in our lab, our scientists are pretty good, like if they see someone who's got sterile pyuria, they look back and see their previous urines and see how prolonged it's been. Like if it's been, particularly a lot of the oldies who aren't at risk of STIs, we often get many instances of sterile pyuria. And if we see that, we treat it almost like we would a invasive specimen, like something we get from a cystoscopy. And what we do is we incubate for a bit longer. We get some extra plates. So we get some chocolate agar, we set up anaerobes, and we sometimes would set up a fungal plate. And we use the larger microliter loop instead of the 1, we use the 10. So we go down to 10 to the 5. And that's just to see if we can get anything pure growth or anything unusual that might have been slower growing and causing problems. So we do like to know. So if we see that on a request form, we would set up those things. So the next, a 75-year-old male with fever, polyuria and dysuria, lots of white cells, lots of blood, no epithelial cells. He's grown pure growth of E. coli. I'm getting a lot of mileage out of this slide. And this is the sensitivities that have come back. Now this is what our machine that spits out the sensitivities looks like. And then we release things to you. We often hide some of the things when we can, like things such as meropenem or unless it's the only option. If you can see here, it's very limited options. You've got augmentin, tazocin, cefoxitin, meropenem, amikacin. So it's quite resistant, and nitrofurantoin. This is an ESBL. It's resistant to 3rd generation cephalosporins, so ceftriaxone resistant, ceftazidime resistant. So this gentleman would probably be treated. I mean, you can get away with augmentin for ESBLs if it's susceptible. It's okay in the urinary tract. But if he was in septic shock, generally would use amikacin and meropenem. So you treated him for a week with nitrofurantoin or augmentin, and then he represents 1 month later with the same symptoms. Urine looks similar. We've grown the same organism, and it's exactly the same sensitivity profile. So what are you worried about? Yeah, so look, it's a relapse. Well, Gordon was about to write. I know Gordon was going to write relapse. Good, Gordon. No. So relapse is basically that relapse UTI is essentially a partially treated UTI, and you think about relapse when you see an identical organism with the same species, same sensitivities within a relatively short space of time. Most often within a month, but it can be a little bit later depending on the organism. And generally it's because of an inadequate antibiotic course, either duration or resistance. And it often reflects urinary tract complications, such as, adherence to treatment is a consideration, absolutely. So urinary tract complications such as pyelonephritis, prostatitis, orchitis, abscess, or if there's hardware like stents. And when there's a relapse, I think it's wise to do imaging if it's a male. Think about the prostate, and occasionally cystoscopy may be indicated if you're getting multiple relapses, if you're particularly after treating them for a complicated UTI or treating them for one of those scenarios. I've seen some funny organisms or funny organisms causing prostatic abscesses in, particularly in patients with risk factors like transplants. Now it's different from recurrence. So recurrent is 2 or more symptomatic infections within 6 months or 3 or more within 12 months. And I think to call something recurrent, you need at some point to have microbiological evidence, and at least ideally more than one occasion, but at least one occasion. First thing to do is to consider alternate diagnoses, so vulvovaginitis, an STI, a non-infectious cause of symptoms. Consider unusual pathogens, something like tuberculosis. Now, sometimes tuberculosis can respond to aminoglycosides, so you might get a bit of a hiatus, but typically you wouldn't to one dose. And consider risk factors for why they're developing recurrences. So there are some behavioral factors, so sexual practices, the use of spermicides been associated with UTIs, and there's a whole heap of urological factors that can, that I'm sure you're all aware of, that can result in increased frequency of UTIs, such as impaired bladder emptying, such as prolapse, BPH, incontinence, or urological interventions. Now, most data on recurrent interventions for recurrent UTIs is in females, and typically they're relatively uncomplicated urinary tracts. So we've actually got very poor data outside of that setting, which is a bit of a hole in literature. So when it comes to behavioral factors that can reduce recurrences, so fluid intake may be beneficial, and there are studies to support this. Not always possible if the people are on fluid restrictions, but 1.5 litres daily minute is sort of the recommended. Consider contraceptive modification, avoiding spermicides. Now this one's a big one, the next one. Intravaginal estrogen in postmenopausal females is one of the key interventions in that group. And the reason is estrogen actually acidifies the vagina, and this allows organisms such as lactobacillus to thrive. Now, when in menopause, when your estrogen drops, your lactobacillus level, the acidity goes down, lactobacillus no longer becomes the predominant thing, and enterics start living in there. And your enterics are the organisms that cause UTIs. From there, they're able to migrate up the urinary tract. So the lactobacillus, as normal flora, is able to outcompete and prevent some of these enterics from colonizing the area. So I think it's one of the key interventions. Now, manage any urogynecological issues if possible. It's not always possible, but urology intervention may be needed. Methenamine, 1 gram orally twice a day, has actually been shown to have similar reduction in UTIs compared to antibiotic prophylaxis for UTIs. So it's probably a favorable one if it means you don't have to put someone on antibiotics and run the risk of side effects, but only really beneficial in uncomplicated urinary tracts. Cranberry products, the evidence, there is some weaker supporting evidence. So more needs to be done to see if that's possible. So in terms of antibiotic interventions for recurrent UTIs, once again, most data is for females and generally uncomplicated UTIs. There have been some things for complicated UTIs. There are two sort of strategies you can do for patient initiated, or actually 3 strategies, but the 2 sort of intermittent strategies are patient initiated treatment. So you give the patient a script and allow them to start antibiotics when they become symptomatic as per the therapeutic guideline recommendations. You won't get a urine microscopy that way, or you could ask them to do a urine at the same time, but it'll reduce your overall antibiotic use compared to staying on an antibiotic long term. Useful, I think, if you're getting, say, 3 or 4 UTIs a year, but I guess if you're getting more frequent, then it may not be possible. Now, postcoital antibiotics in those who are sexually active has been shown to reduce UTIs, and these are the recommendations as per TG in terms of your dosing. So it's a one-off dose a few hours post-sexual activity. Now, antibiotic prophylaxis, as I said, not that great evidence in males, and it's less likely to be effective in people with instruments and devices. So I don't think it's a great strategy for patients who've got catheters or urological stents. And that's because the UTIs that they're getting are going to be with weird organisms, and whatever you're going to put them on, you're going to select some weird environmental organism. So your things like Suds and Acinetobacters are going to be key players in this, and I don't think your prophylaxis is going to do much to prevent those. Generally, you use the prophylaxis to 3 to 6 months and then reassess. If they have not had a UTI, you can stop and see how they go, or you can push on for a little bit longer. In non-pregnant females, these are your general selections or your empiric selections. But sometimes that might be influenced by your antibiotic susceptibility testing. But once again, if someone has a history of, say, Pseudomonas or Enterococcus, these are less common uropathogens, you probably want to ignore those because that means they're going to be prone to all sorts of weird environmental stuff that your antibiotic prophylaxis is probably not going to stop. I think this prophylaxis is good at preventing things like E. coli, those organisms that can migrate up your urinary tract. And at the end of the day, you've got to balance the risk of recurrent UTIs and versus long-term antibiotics in terms of side effects, resistance, developing changes in your microbiota. your microbiota and the effects of that. I'll address the questions shortly because we're almost actually done. There's a few investigational strategies. So there's some vaccines that are being investigated as like an E. coli vaccine, but protection, and it was promising early, but protection does seem to wane pretty quickly, like after a few months. There are a few immunostimulants available. They're oral stimulants that have preparations of heat-killed enteric organisms, and they've been shown in trials to reduce risk. And one's actually available through SAS Category C. I can't say I've used one of these before, but MV108 is the one that can be available in Australia. But they have been shown to reduce your risk of developing a UTI. This is a nice up-to-date flow chart, which I won't go through, just looking at interventions for a current UTI, just in terms of how to manage it. And I found it quite useful actually, so it's not a bad resource. Now my last thing I'll talk about just quickly, and then I'll go through the questions. You might have noticed there's been a bit of a change in reporting from a lot of labs in Australia. And what we use is something called UCAST, which stands for the European, I think it's, I need to remember it, I think it's the European Commission on Committee of Antibiotic Susceptibility Testing. This is a group that determines what we determine as sensitive or resistant. And a lot of work goes into that, understanding like the pharmacokinetics of antibiotics, the organism itself, and clinical data. Now, most labs across Australia use it. And what has happened recently is there's been around 2021, and it's taken labs a bit of time to react. There has been a bit of a change in the way they report, and more we're seeing I. Now, I doesn't mean intermediate, it means susceptible. Just use a higher dose or increased frequency. So susceptible, increased exposure. So whatever used to be S for some things has become I, and it doesn't mean it's inferior to S. So we still see patients coming to ED with organisms like a Pseudomonas in their urine with Cipro I, and the only things that are S are tobramycin. But no, anything I is perfect, is as good as S, and it's important to remember that. It just means increased, you've got to use a higher dose. It's a prompt to tell you to change your dosing. For example, with Pseudomonas, rather than using 500 milligrams BD of ciprofloxacin, you give 750 milligrams BD. And UCAST does have resources telling you what dose to use. So this is just a table showing the means of increasing exposure. Most of the time it's increasing dose, but sometimes it can be frequency. So I'll stop there. I won't go through multi-resistant organisms because we won't really have the time, but we will address some of these questions. So going through what we've got here. So Georgia mentioned initially, if an organism is sensitive to the same antibiotics, would you treat with a different one this time with a relapsed UTI? I guess it depends, Georgia. Like I think if we're thinking it's relapsed from something like prostatitis and we treated with nitrofurantone, then yeah, I would use a different antibiotic because nitrofurantone is specific for the bladder. But if we say if we say had Cipro as an option and we used Cipro and we gave Cipro for 5 days and then they relapsed, and then I found they had something like prostatitis, I would use Cipro again, and I would give like a longer duration. I'll treat prostatitis for 2 weeks if it's acute. So yeah, I guess it depends on the antibiotic I used, and whether I think it's what the source of the infection is, whether it's confined to the bladder or somewhere else. Does postcoital voiding work? There is some evidence to suggest it's beneficial. Like I think it's a small postcoital voiding. I misread it as postcoital antibiotics. I don't actually know. I don't think it would do harm, and it probably. I haven't actually looked at the literature on that, so I can't imagine it would harm, and I imagine it's fairly easy to do, and probably would help, remove things like Staph saprophyticus in your urethra, probably flush it out in a way. So I think the theory sounds good. Now, Georgia mentioned some urologists do rotations of prophylactic antibiotics every month, like Trimetha and Keflex. What do you think of that? I would say it's not an evidence-based approach. I think I don't think it would be good for the microbiome. I think you'll be high risk of developing resistance. I think if you are going to rotate, you probably want to go a little bit longer. And I think I'd use it as a last line. I think I'd probably do, 3 months or 6 months of Keflex, and then if they're still having UTIs on that, then I would rotate to something else. I'd probably use failure as my means to rotate rather than just do it prophylactically rotating. I would just go Keflex for 6 months, and then if they keep on getting UTIs, I'm like, all right, I might try trimethoprim now because this hasn't worked. And the trimethoprim hasn't worked, let's try nitrofurantone. Your microbiome does generally recover within, it's probably like 4 weeks. So maybe after a month of trimethoprim, you'll have a month off trimethoprim, your flora will change a little, but I don't think it's. I think if you're going to do it, I'd probably do it more as a reactive thing rather than a proactive thing. Now, fistulas. I don't think you can prophylax against fistulas. Unfortunately, a fistula is. It's basically your bowel emptying into your bladder. And no matter what, you're going to get unusual bowel organisms in there. No matter what you put them on, you're going to select something resistant. We can't, prophylaxis in a way has to be semi-targeted. I think the prophylaxis that we're using in UTIs, it's almost an exception because it's not as targeted, but we are really targeting E. coli. Like we know E. coli is the big player here, and I think the evidence for prophylactic antibiotics where it has been successful, I think the ones we're preventing are probably those E. coli UTIs. Your bowel, in something like a colovesicular fistula, they're horrible. It's really difficult. And really the only thing you can do is surgically manage those. In a 93-year-old, you're not going to probably be able to do that. No one's going to be willing to do that. I probably would just do a patient-initiated antibiotic strategy for those. I don't think prophylaxis will work. I think you're just going to select resistant stuff from your there's just going to be too much bowel bugs flooding in there.
Awesome. Thank you so much, Tony, for that deep dive into UTIs and taking us behind the scenes of what happens in the labs, especially when we see those reports. So I'm sure we're going to be looking at those reports and knowing what they mean, especially that eye for the susceptibility and the increased dose use. That's definitely going to be a game changer for me. So
yeah, it's good to know, because I feel like they just jumped over to eye and didn't really give an explanation to anyone. So or many labs did, and I think even with us, like, we let like our local clinicians know, but the community, often you guys don't get that explained to you. It's just a sudden change, and then you have to deal with it.
Yeah. No, we're used to that in GP land, but thank you so much for your time. And I'll hand over to Rochelle for the wrap up, and I'll see hopefully a lot of you tomorrow night at GP Club.
Awesome. Thanks, Georgia. Yes, again, thank you for everyone for joining us, and a big thank you to Tony for taking the time this morning to present. Just a reminder to everyone, the QR code and the link for the Slido evaluation is in the chat. So if you have a moment to complete that, that would be great. And yeah, GP Club tomorrow, we will see you all there. Thanks, everyone.
Cheers. See you all.
See you, everyone.